The first symptom that filmmaker Simon Fitzmaurice experienced was the slapping sensation of his foot on the pavement when he walked. Fitzmaurice said, "It was like my foot has gone to sleep and is limp." As his condition progressed relentlessly, he consulted a neurologist who organized an electromyogram, or EMG. It was only after this that the neurologist made a diagnosis of motor neuron disease and gave Fitzmaurice the dire prognosis of 3 or 4 years to live. In his illness memoir titled "It's Not Yet Dark," he wrote that his first impulse was to deny the diagnosis and the prognosis. This is why he said he and his family pursued every thread, every possible mimicking illness, every alternative blood test, every experimental trial. This approach, he said, gives us hope, a focal point to lift our eyes from the life that lies in tatters all around us. Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast, where we will continue our exploration of the dreadful disease, motor neuron disease. In the last 2 podcasts on this theme, we reviewed quite a few of the clinical dimensions of the illness. In this episode, we will focus on its investigations and management, as well as the impact on the family in the terminal stages. The initial management of MND involves the investigations to confirm the diagnosis, and Fitzmaurice highlighted the role that EMG played in his case. This test entails inserting needles into various muscles and recording the muscle activity on a screen. The features that the neurophysiologist who inserts the needles looks for in such cases include fasciculations and fibrillations. Technical terms you don't have to worry about too much. And mind you, he hunts for these everywhere, including the tongue, and occasionally even in the muscles of the larynx. Fitzmaurice also referred to the blood test he had to have along the way. Most of these were done to rule out the mimics of MND and also to assess for the presence of its complications. As appropriate, these tests include the inflammatory marker called CRP, or C-reactive protein, glucose, syphilis screen, protein electrophoresis, thyroid function test, the muscle enzyme called creatinine kinase, and a raft of antibodies. Other blood tests less often done are screening for heavy metals, Lyme serology, paraneoplastic antibodies, and appropriate tumor markers. Serum hexosaminidase A and B may be required in young onset MND, and very long chain fatty acids called VLCFA may be checked if there's associated adrenal insufficiency. Genetic tests may also be done in appropriate situations to look for such genetic mutations that may give rise to familial motor neuron disease. Genetic tests are also required to look for the mimics of MND, such as Kennedy disease called bulbospinal muscular atrophy, and other forms of spinal muscular atrophy. Neurologists also often request an MRI scan of the brain and upper spine when investigating people suspected of MND. This is mainly to rule out some MND mimics such as cervical spondylosis, compromising the spinal cord and compressing the nerve roots that exit from the neck. The brain MRI may also occasionally show characteristic features of MND, and these include thinning of the primary motor cortex. And in the subtype of MND called primary lateral sclerosis, the MRI may show several abnormalities. These include atrophy or thinning of the corpus callosum, thinning of the cervical spinal cord, and high intensity in the corticospinal tracts. These are the motor nerve fibers descending from the brain and running down the sides of the spinal cord. After making the diagnosis of MND comes the heavy task of breaking the bad news. Disclosing the diagnosis of any condition is an onerous task, but this is more so with conditions like terminal cancer and perhaps even much more so for the diagnosis of MND, which has the additional burden of no curative options that many cancers now have. The impact of a badly delivered diagnosis of motor neuron disease adds to the emotional burden of the disease itself. An illustrative example of breaking bad news gone bad is that of Peter Anderson, as recounted in his memoir titled Silent Body, Vibrant Mind. There, he wrote that his neurologist explained that this is a very serious condition for which there is no treatment or cure, and that his symptoms would in all likelihood continue to progress, initially to paralysis. His neurologist, he added, also gave him a 2 to 3 year prognosis before death. Anderson said the news was delivered like a bombshell, and that his initial reaction was one of total shock and incomprehension. But more incomprehensible for him was his disappointment at how his neurologist delivered the news, an experience that he said rankled with him years after the event. Anderson acknowledged that there is no way to cushion the blow of such a distressing diagnosis, and that he appreciated the candid and informative way in which he was given the prognosis. Nevertheless, he was disappointed because he said there was no emotional or personal support offered immediately after the news was delivered. And worse still, Anderson said the neurologist offered little comfort or succor after delivering the news. Whilst there are many recommendations on how to break bad news, one that I have personally found most helpful was that depicted by medical doctor Kate Granger in her second memoir titled The Bright Side. On treatment for cancer herself at the time, she narrated how she went about delivering the news of incurable lung cancer to a man who had presented with brain metastasis. On the understanding that he has the right to know as much or as little about what is going on, she said, "I sit next to his bed and take his hands. After a deep breath, I ask what he understands so far about his illness and how much he wants to know." She said, although frail, he is complete all there mentally, and he wanted to know everything. She then said, with as much compassion as I can muster after an appropriate warning shot, I tell him he has advanced lung cancer that we are not going to be able to treat as he is just too poorly. As she saw him fighting to keep back his tears, she rubbed his arm and reassured him that it's okay to cry. With that permission, she said, he lets go and is in floods of tears. After he had composed himself again, she told him that she will be available to talk to him again later in the day if he wished. Sandra Donalds also made many insightful suggestions on how to break the bad news of MND, insights that she gained from witnessing her mother's experience of the diagnosis of the disease. Writing in the illness memoir titled A Beautiful Smile, Donalds wrote that when giving bad news, practice empathy and compassion. Be sensitive to the fact that the person you are informing may be so stunned that they misinterpret, completely deny, or even refuse to hear. Be sensitive to their emotions. Disbelief, shock, numbness, and anger are all part of the process. Going further, she advised doctors breaking the news to let the patient know that you care and are as concerned as they are, and to try to refrain from letting your emotions take over and make the situation more tragic. And when answering their patients' questions, Donalds said doctors should try not to go into too many details during this initial discussion, especially if they are in denial. She especially cautioned them to be realistic and don't make the situation worse by offering unrealistic statements that offer false hope. Importantly, Donalds advised the newsbreakers to try to refrain from making such statements as "it hurts me as much as it does you," explaining that these statements don't offer much sympathy because you really don't know how they feel. On the contrary, she said, what does help is for you to be a sounding board and listener rather than a problem solver, and that the onus on the doctor is to be honest but not hurtful. The rapid lethality of MND is probably the most devastating aspect of the diagnosis of the disease. This is illustrated by Fitzmaurice, who contemplated the inevitable mortality that his diagnosis imposed on him. He wrote that when you are told you will die within a certain time, time slows down. Life becomes dominated by the last time. He became obsessed with the thought that every time he did anything, it may be the last time he did it. As his condition inevitably deteriorated, he wrote that MND progresses, does its own thing, works on its own timeline. The gloomy fate of people with MND may explain why denial may be their first response on receiving the diagnosis. For example, Fitzmaurice wrote of how denial made him pursue treatment with everything I have. Determined not to die like this, he said he visited all sorts of healers and tried countless alternative treatments. Eventually, however, acceptance sets in. He said, I realize I have a simple choice. I can accept that I have MND or I can give up. I realize that I have been carrying around the burden of responsibility for having MND. With this turn in perspective, he focused on celebrating the things MND hadn't deprived him, from sexual potency to the ability to move his eyes and facial muscles. But he also acknowledged that MND sometimes lays me so low that I don't know how I will go on. Another account which conveys the need to face the gloomy diagnosis of MND with as much positivity as possible is that of Marcel LaPerriere in his illness memoir titled Just Another Adventure. LaPerriere referred to MND as a monster that will strive to make life more and more challenging, not only for the person with ALS, but everyone associated with that person. It is in this context that he repeatedly emphasized that even when we know how we are going to die, life is too short not to do our best to be good people and to love the people we love. He added that the ALS monster tries to give me bitterness each time it takes something away from me, but I'm not going to let it. I'm still looking at all the positive things I have in my life, and they far outweigh the negative. Asserting that bitterness is the one disease that is self-inflicted and should be avoided at all cost, he reflected that being depressed, bitter or angry doesn't help the situation, but rather makes it hard for everyone around you. This is why he said, I've resolved to do all I can to stay happy. It is on this premise of looking at the brighter side of things that he said, ALS sucks, but life is good. He went on to illustrate this with how he finds joy as much in the love of his wife as in his little dog lying on his feet. He also wrote of the pleasure he gets from his dreams and from recalling the fun adventures he has shared with his wife, maintaining that it's those memories that will always be stronger than the ALS monster. Another person who demonstrated a positive approach to the mortality of MND was Ulla-Carin Lindquist in her memoir titled Rowing Without Oars. After a conversation with a chaplain, she also conceived herself to be in the borderland between life and death. The chaplain had said, "Death for me has two faces. One is grief, pain, and fear, but sometimes, just at the juncture between life and death, something else happens. Something very beautiful, peaceful, an unbelievable peace, sometimes almost joy." For others, the disability caused by MND is the overriding concern. For example, Spencer Wendell, in her memoir Until I Say Goodbye, wrote of dreading the future of ALS, saying, "What I feared most wasn't death. It was being entirely dependent on others, a burden on my family and the ones I loved." Spencer Wendell also bemoaned the embarrassment, the shared tears, the envy, the depression, and the thoughts of suicide that often accompany MND. She nevertheless made end-of-life wishes, poignantly depicting how she chose to live the rest of her life with joy, spending valuable time with the people she loved. All the stories here are side reminders that medical research has yet to come up with an answer to the ravages of MND. It is a matter of regret that none of the available approaches to the treatment of MND stops or even significantly slows down the progress of the disease. Take riluzole as an example. This is a medicine that is recommended for MND because it slows the progression of muscle weakness, but it only improves survival by about 3 months. Riluzole is administered by mouth, but it requires regular blood tests to monitor for the development of liver dysfunction, one of its several side effects. Another example is edaravone, which is used along with riluzole. Edaravone is administered by intravenous infusion and may improve strength and delay progression of the disease, but also to a limited extent. Edaravone may also provoke allergic reactions, bruising, and headache. Perhaps more promising than riluzole and edaravone is tofersen. This so-called antisense oligonucleotide is a gene therapy that is indicated for those with the SOD1 or SOD1 gene mutation that causes some familial forms of MND. Tofersen is administered into the spinal cord and can cause such adverse effects as pain, fatigue, muscle and joint aches, and occasionally inflammation of the spinal cord and the nerve roots, called myelitis and radiculitis, respectively. Thankfully, there is a host of investigational treatments of MND in the pipeline, which will hopefully be better than what is currently available. But even if medications do not cure MND, a lot can be done to make the experience of the disease less distressing. For example, there are many treatments of the neurological symptoms and complications of MND, such as spasticity, cramps, labile emotion, pain, anxiety, fatigue, and insomnia. There are also treatments for MND's non-neurological symptoms such as constipation, drooling, shortness of breath, spasm of the larynx, and even excessive yawning. And there are also a lot of supportive measures available, some of which can delay death even if for just a short while. These include dietary and nutritional modifications, care of secretions, measures to improve eating and swallowing, and the use of percutaneous endoscopic gastrostomy or PEG feeding. Examples of the benefits of these interventions are evident in many of the MND illness memoirs we have explored so far. For example, Sandra Donalds described how antidepressants relieved her mother's anxiety around choking. She also showed how a nebulizer helped her to clear her airway of mucus, improve her breathing, and reduce coughing, and how a reclining lift chair is worth every penny. Marcel LaPerriere also detailed the benefits he got from his powered wheelchair, his feeding tube, a BiPAP breathing machine, and medications such as mirabegron, which reduce the frequency of going to the toilet at night. He also found value in baclofen in reducing his spasticity. Similarly, in the memoir titled Join at the Hip, John Hardwick wrote of the interventions his wife benefited from. For example, he wrote of how a stair lift relieved the burden and risk of climbing upstairs, and how he banked her voice, a process which only required her to read and speak 50 sentences into a microphone. But perhaps the only intervention that can sustain life in MND is artificial ventilation. For example, when Simon Fitzmaurice started experiencing recurrent chest infections and developing respiratory failure, he was put on a ventilator. However, this happened only inadvertently because this intervention is not routinely offered to people with MND in many countries, including his native Ireland. This is because, as his neurologist explained to him, the poor prognosis of MND limited the benefits he would derive from being on a ventilator. But Fitzmaurice viewed things otherwise. He saw this advice to decline ventilation as a call for him to commit suicide or euthanasia, and he opted to remain on the ventilator, on which he was eventually discharged home. Fitzmaurice criticized the policy of not offering ventilation to people with MND, and he disparaged the hardness by which neurologists relay this information to their patients. He therefore argued that people should be given the choice of whether to ventilate or not, arguing that life is a privilege and I feel privileged to be alive. He added that I am not a tragedy. I neither want nor need pity. I am full of hope. Although he acknowledged that life on a ventilator with MND isn't something everyone with the disease would choose, he nevertheless maintained that for those of us who choose that life, I believe we need real advocates to support our choice. He further admitted that life on a ventilator came with significant challenges, such as when he wrote that I do not eat or drink or talk the way you do. I don't breathe without a machine helping me day and night. I cannot move my arms or legs. To discuss the management of MND further, I will be speaking to Kevin Talbot, co-author of the book titled Motor Neuron Disease, and this will be in the next podcast on this subject. Thank you very much for listening to or watching this podcast, in which we explored further the management of motor neuron disease. If you found the podcast enlightening, educational, or helpful, why not click on the like button and consider subscribing to the YouTube, Apple, or Spotify channels of this podcast. And you might also want to check my book, Surfing the Brain, for more down-to-earth approaches to neurology, and my neurology database called Neuro Checklist for more of the academic dimensions of the podcast. Thank you very much for your time, and do join me in the next podcast when I will be speaking to Kevin Talbot.